Thank you so much, Dr. Anuj, and I must thank Diabetic Asia Study Group, Dr. Basi, Dr. Bansi Sabu, Dr. Nadima, and everybody for keeping the topic of prevention and involving the phenotype. We had a very elegant presentation by Dr. Kunti on phenotypes. And we know that Asian phenotype is different. We are similar and dissimilar in many ways. I don't have any duality or conflict of interest for this talk. I hope what you listen, you will learn, what you learn, you will adapt. It's a postprandial time, and we know diabetes in Asia particularly has moved from an epidemic to a pandemic. We are thin fat in many ways, at least in Indian. Asian is a much broader term, and I'll allude to that a little later. Is it genetic or familial? Probably yes. Is it linked to sedentarism or activity? Probably yes. Is it linked to too much of calories? Probably yes. Do medications respond differently in Asians? Possibly yes. Are there transcultural algorithms? Probably yes. So we have clusters and recommendations, but today our goal is to look at various prevention trials which have been done and how are they different in the Asian population, and we have a few of them. So when it comes to phenotype, we did a screening program called Screening for the Twin Epidemic much before the ICMR INDAB, where we screened 8 states of India, 16,000 population, primary care, first 10 people who walked in the clinic for any complaint, cough, cold, fever, and we found that 80% of them had either type 2 diabetes or hypertension, and the single most common factor which was determining or driving hypertension or diabetes as a twin epidemic was the waist circumference or truncal obesity. So when we moved from village to town to city, the driving gradient was abdominal obesity, and therefore our phenotype, at least in the Indian geography, is we have more fat, less muscle. We have sarcopenia, which is muscle mass is less. We have abdominal obesity, it's probably familial. It's clearly environmental. We are becoming more and more affluent, and we are becoming more and more sedentary. And this was seen in the New York City when Marianne Banerjee with Harold Lebowitz published this paper almost 30 years back, where she showed that people from Pakistan, Bangladesh, India, who were cab drivers, when she compared their body fat, and normal people between 20 and 45, compared their body fat with African Americans and Caucasians, the Asians from our geography or Southeast Asia, and Professor Azad Khan is here from Bangladesh, who's our Southeast Asia chair, clearly showed that we, in the non-obese Asian Indians, we had more body fat in our body composition. So clearly the thin fat phenotype or the Asian phenotype carries more fat at the same BMI, whether it is total or abdominal region. They have less lean muscle mass and bone mineral compared to other ethnic groups. So if you have a person with a BMI of 32, and if red is the lean mass and white is, yellow is the fat mass, person A, person B and person C, clearly person A is probably of Asian ancestry, while B and C is probably of non-Asian ancestry, is a conclusion which people alluded to. So clearly different BMI, same lean mass also, a similar application can be made. And therefore the face of the Asian phenotype is the face of the modern malnutrition. And this is a global graph that the low lean mass present across all body weights and BMIs is the new face of our phenotype from Asia. And therefore if you look at the low lean mass of sarcopenia in Asia, not just south of east of Asia, but even if you look at east of Asia, studies from Hong Kong, Taiwan, China, Korea, Japan, and then of course from India, Bangladesh, Pakistan, and our geographies, Nepal, Sri Lanka, clearly there is an underpinning of a sarcopenia or low muscle mass. So clearly our phenotype is central obesity, obesity at a lower BMI. What is driving it? Probably too much of food, mainly too much of carbs and too much of fat and very less protein. This was the START study which we published almost a decade back in the BMJ Open then. where we showed that India has excess fat and carbs and very less protein in the non-diabetic as well as the diabetic population, and compounded by a sedentary inactivity, whether it's watching any gadget, television was a classic one, or a computer screen or a mobile phone, and then of course we are less fidgety. So we have dropped down our non-exercise activity thermogenesis or NEAT, and therefore a typical agrarian Asian who was always an agriculturist has dropped down a NEAT of 2000 kilocalorie per day to a non-activity exercise thermogenesis of 700 kilocalorie a day. So clearly our phenotype has more fat, less muscle mass, mitochondrial defects and insulin resistance. And that actually leads to a lot of heart disease. And this was replicated by Dr. Manisha and Nicole Abate from Texas, Dr. Anji Raji from Boston and Harvard, and they clearly showed that at a comparable value of body fat, Asian Indians had higher insulin resistance, and typically our phenotype has thin fat or more abdominal fat, more insulin resistance, lot of inflammation or meta-inflammation, low adiponectin, typical dyslipidemia of low HDL, high triglyceride, and clearly we can recognize that we have more susceptibility to coronary artery disease and type 2 diabetes. Do we respond better to drugs? This was a study which our student from pharmacy did, typically presented long time back at IDEA Montreal, now published. Pioglitazone, 7.5, 15 and 30, the glucose reduction is the same, but the Asians respond better even at the lower dose. The study done in a gliptin, because we eat more carbs, the Indians and Koreans drop the A1C in a gliptin like sitagliptin by 1.36 because we have a higher carbohydrate exposure. In the Caucasian world, gliptins are not popularly used. They drop the A1C maybe by 0.6 or 0.8, but in our world we use a lot of it. So therefore there are need for ethnic specific guidelines for prevention, and many of us tried to look at different cut points, and we had physical activity guidelines, which is not 30 minutes 3 times a day, it is 60 minutes of physical activity every day. Then we had dietary guidelines of less carbs, less fat and more proteins, and then we had this consensus statement which came out for Asians on physical activity, medical and surgical management. We also see that in Asia and worldwide, due to use of ultra processed foods, we are fibropenic and we are having less and less fibers. Again, Dr. Sabu was the first author of this paper, many of us published this, that we are having less and less fiber. We are also getting clusters now, because type 2 diabetes is very heterogeneous, and many of us compiled this paper, but predominantly coming from Professor Mohan's group, and you could see that we have severe insulin deficient diabetes, insulin resistant obese diabetes, combined insulin resistance and deficient diabetes, and mild age related diabetes. So clearly you can see, and they have a differential complication impact from the cluster, and therefore we can subclassify that. So we are having adiposopathy, and we clearly recognize that when we are treating people with diabetes in this part of the world, phenotype matters. We cannot just be glucocentric. We need to look at the weight, the obesity, the fat, the ectopic fat, and so on and so forth. And therefore global guidelines and Asian guidelines vary, because we see spectrum of people in our clinic: malnourished, lean, thin built with central obesity, normal weight, normal built, overweight, obese and morbidly obese. So we clearly see that global guidelines are not necessarily suitable for Asian population, because we see a lean and non-obese person with diabetes, we see people with ketosis proneness, and we clearly see that we definitely have other drugs like alpha glucosidase inhibitors. So one size doesn't fit all, and therefore we need to tailor it. So when it comes to prevention of diabetes, which is my strategy for Asian phenotype in the last 10 minutes, I will allude to prevention strategies. And in the Asian phenotype, are we going to be different? 1921, more than 100 years back, Professor Elliot P. Jocelyn wrote this paper in JAMA on prevention of diabetes mellitus. And I don't think there is much change between what he wrote on 8 January 1921 and today. In type 2 diabetes prevention, there is a slow progress in population in RCTs and robust research is lacking. There is a lack of agreed upon definitions. Early studies hindered by absence of standardized definitions. Behavioral change is tough and clinical settings to adopt these trials are not easy. Evidence-based guidelines only came up in the 70s, and by that time diabetes had exploded as the population exploded. From 1972, where world was 4 billion, today in 2023 the population doubled to 8 billion, but we have an explosion of type 2 diabetes population of almost close to 1 billion. 1 in 8 people on planet Earth are living either with diabetes or pre-diabetes. So for a successful disease prevention, the prerequisite is an agreed diagnostic criteria, understanding risk factors and natural history, affordable and acceptable screening, and modifiable risk factors which are acceptable for a strategy change. And therefore we need to look at experiments which are proof of concept to a population level implementation. And therefore we need to design trials which will reduce risk among high risk. If they are successful, then scale it up to population level and then integrate those mega trials into national prevention policies and postpone the onset of type 2 diabetes. One such very good exercise which our Chinese brothers and sisters did with the help of Barbara Howard and Peter Bennett's group is the Daiqing IGT diabetes study, which looked at effects of diet and exercise in preventing type 2 diabetes then in the IGT population from North China in 33 clinics. 4 groups, diet alone, exercise alone, diet and exercise and control. Clinics, no individual participants, randomized to different intervention protocol, robust intervention supporting lifestyle modifications, work. So Asian evidence here, robust Asian evidence in clinic practice to show that in North China, 33 clinics, it's possible. The Finnish diabetes program also then came out with a similar protocol with lifestyle outcomes on healthy diet, physical activity and weight reduction, and their first year results were compelling, and after intervention their 4-year results were more compelling from the Finnish diabetes program, which looked at less consumption of lower fat, sat fat, high fiber, looked at aggressively looking at weight regain and various other strategies. The most compelling prevention trial on planet Earth is the DPP program, which is the diabetes prevention program in United States funded by the NIH, and that program, which came almost 2 decades back, had intensive lifestyle, standard lifestyle with metformin, standard lifestyle with placebo, and 58% reduction, just like the Finnish program, showed type 2 diabetes risk during intensive lifestyle, and this risk was reduced to a large scale. Professor Ramachandran designed the Indian diabetes program, and in that program we were able to show that the lifestyle intervention was not as robust, and he had an IDTP 1 arm and IDTP 2 arm in which there was metformin as well as there was pioglitazone in the second part. Lifestyle worked, but it was not as robust as the Caucasian data or the Chinese data because of the low lean mass. When we looked at the Japanese trial of men with IGT, again when we compared a 4:1 randomization of standard intervention versus intensive lifestyle, you could see a compelling impact. So when we look at the Daiqing study in China, the Finnish study, the DPP program in the US, the Japanese trial and the Indian trial, clearly you can see what is underpinning: lifestyle, dietary change, weight change, and the sedentary habit going away. And there was a long-term follow-up for Daiqing, which is available. For Finnish study, as well as DPP-4 program. Unfortunately for the Japanese and the Indian trials, we didn't have long-term follow-up, which is something which we need to recognize. So when we compare these various RCTs in the type 2 diabetes prevention trials, we clearly see what are the common denominators. And the common denominators are very, very clear. Energy restriction, fat reduction, increased fiber. Weight loss varied significantly, and I don't like the word weight loss now. Fat loss is more important than weight loss across trials, with notable success in DPP-4 and DPS, the Finnish and the American trials. Clearly, the physical activity was emphasized across goals, including the daily walking habits in the Japanese trial, and the long-term follow-up looked at assessment of sustainable intervention. The relative risk reduction varied, and the Japanese IGT program had the highest reduction of 67%, with lifestyle interventions consistently outperforming all other methods. If lifestyle reduced or prevented diabetes in 2/3, all other drugs reduced it by 1/3. It remains to be seen whether the new ticket drugs like SGLT2 inhibitors, which are generic now, or the GLP-1 receptor agents which are coming in now, if they are used in the prevention space, what will be the outcome? But there is no funding for that. The other key important thing is the risk reduction from all these RCTs, which I alluded to, was consistent. The prevention effect in lifestyle was quick and fast. It was gender neutral, and it was across all ethnicities. So it really didn't matter whether you were Asian or non-Asian. But when we looked at lifestyle intervention, independence from initial body weight, multifactorial benefits, postponement of type 2 diabetes, residual risk and genetic risks are varied. And that's something which we need to recognize. For example, if you look at a 30-year follow-up of Daiqing from the Chinese cohort of North China, you can see this paper that people with impaired glucose tolerance who reverted to normoglycemia or remained with IGT had lower risks of cardiovascular disease and microvascular complications. So you could actually see the impact of metabolic memory, which was seen in UKPDS in overt type 2 diabetes, was also exploited in the Asian population. So clearly you can see that in the post-trial follow-up in the long term, at least there is a 20% risk reduction of type 2 diabetes. The DPP outcome study showed only a 6% reduction. The Daiqing 30-year follow-up showed 49% reduction. And the Finnish program had a differential effect. So ethnicities do matter, phenotype does matter, and the fat to muscle ratio does matter. This is again an impact of 10-year follow-up of the diabetes prevention program outcome study from the DPP group. The other focus point of intervention is fundamentally the youth. The Yale Bright Body study and the US Latino study again underpinned the same thing, as well as the Finnish DECO program and FIN-DO-DO program had the same impact. And you can clearly see that the impact is very clear, and probably you need to have a practical tool. And JACO came out with this practical tool to predict the risk of type 2 diabetes, and now many people have integrated that and it's been translated across it. But the challenge in low and middle income countries is global disparity of high income focus, emerging studies, implementation approaches, and stakeholder participation. And therefore we need to keep doing work which are landmark trials, which have a global impact, which have sustained benefits, and there is an ongoing challenge. From the ICMR INDAP, I borrowed this cutting from Professor Mohan, we are a part of it, that you can actually look at remission. Remission is a reality. Just by reducing carbs and adding proteins, you can do remission. We have shown it in RCT, and you can clearly see that. And therefore, if you want to make a change in our phenotype, we need to hard hit mantras of prevention, like eating slowly, eating less, eating on time, eating it right, walk more, do some yoga, sleep well, and clearly look at just not outcomes of health, but also look at outcomes of happiness and do some digital detox. And my final slide is that the fat to fit debate, because we are in a Fit India movement, and the fat versus muscle debate is time is muscle. The more muscle you build, the more muscle we build, the better is a chance of our phenotype to burn that little extra fat from either the ectopic site, and that's the key. And if we are able to do that, we will maybe able to make an impact in our phenotype, in our Asian phenotype, because the world's population of diabetes is predominantly in the Asian continent. And therefore, let's not waste muscles, but activate them with exercise, mainly resistant exercise, and that's the key to diabetes prevention apart from eating less. Thank you so much for patient hearing.